Morning, everyone. Today's debate will be between Shaswat and Ashutosh. This is a question of maintenance therapy in advanced metastatic colorectal cancers, and this is a debate of not just survivals but also philosophy in terms of how you treat your patients with metastatic colorectal cancer. So we'll start off with Dr. Shaswat. He will speak for around 10 to 12 minutes. Then we'll have 2 to 3 minutes for questions, followed by then Ashutosh for the same duration. Right. Let's start, Shaswat. It would be also nice if you can put your face on screen, Shaswat.
Mm, Yes, sir.
Yeah.
Good morning, respected teachers and colleagues. So, today in debate, we are going to discuss regarding maintenance chemotherapy versus no maintenance in advanced colorectal cancer. And I will be speaking regarding I am for maintenance therapy in colorectal cancer. So, So, as we all know, colorectal carcinoma ranks among the top 5 most frequent cancers according to Globocon 2020 data. And first-line therapy for advanced colorectal carcinoma is based on oxaliplatin and irinotecan in combination with leucovorin 5-FU with or without biological therapies. So current standards recommends a strategy of continuing therapy until progression or excess toxicity. So the first landmark trial which led to the concept of maintenance, that whether we can de-escalate treatment and we can put patients on a interim maintenance, came from this study Optimox 1. So this was a landmark study. In the recruitment, they recruited patients with histologically proven colorectal cancers who had unresectable metastasis. They were not exposed to prior chemotherapy except if they have received adjuvant chemotherapy that has ended more than 6 months before the study entry, and ECOG PS less than or equal to 2, adequate hematological, renal, and liver functions, and those who were less than 80 years. So at the time when there were this recruitment was going on, the standard of care was FOLFOX 4 until progression. So what they compared was that whether they can de-escalate. So they say in this arm B, they took they gave 6 cycles of FOLFOX 7. They modified the regimen also, and in the interim maintenance they gave 5-FU leucovorin for 12 cycles, followed by 6 cycles of FOLFOX reintroduction. So what are FOLFOX 4 or FOLFOX 7 and this 5-FU leucovorin? So as we can see in the diagram, in FOLFOX 4, we have leucovorin along with 5-FU bolus 400 milligram per meter square with 5-FU infusion of 600 milligram per meter square on day 1 and day 2. And oxaliplatin dose is 85 milligram per meter square on day 1. For FOLFOX 7, is 5-FU 2400 milligram per meter square on day 2, and leucovorin 400, and oxaliplatin dose is 130 milligram per meter square. In the 5-FU leucovorin infusion arm, it was leucovorin 400 milligram per meter square for 2 hours, followed by 48 hours of 5-FU infusion at 3000 milligram per meter square. So FOLFOX 4, as we already said, was the standard of care at that time. So in FOLFOX 7, the 5-FU bolus was not used, and it has shown to reduce the incidence of neutropenia. So, and oxaliplatin reintroduction was found to be clinically effective in observational studies. And so they planned the stop and go approach for oxaliplatin to reduce the peripheral neuropathy. So this was mainly planned to reduce the toxicity. So they took a duration of disease control strategy. So they divided patients into three subcategories: those who are receiving Folfox and after that Folfox maintenance, and if they will re-challenge Folfox if there's PD, and if there after re-challenging if there's PR and stable disease, they will take the duration of disease control till the time there's PD after Folfox reintroduction. In the B, as we see that after Folfox reintroduction, if there was PD and after Folfox reintroduction there was best response is PD, then they will take the PD before Folfox reintroduction as the duration of disease control. And if the patient has a PR or stable disease after maintenance and we started Folfox, then when the patient progresses, the whole duration will be taken as duration for disease control. So if we look at the results, so the Folfox 4 versus Folfox 7 approach, the response rate were similar, 58.5% versus 59.2%. PFS were also similar, 9 months versus 8.7 months. This duration of disease control was 9 months versus 10.6 months, and OS was 19.3 months versus 21.2 months. And grade 3 or 4 neurotoxicity was 17.9% in the Folfox 4 versus 13.3 in the Folfox 7 arm. As shown in the graph also, the number of patients with grade 3 or grade 4 peripheral neuropathy were less in the Folfox 7 arm, and those also with grade 3 neuropathy were less in the Folfox 7 arm. So, after this, they tried whether to compare whether we can keep on maintenance or we can discontinue the treatment. So they planned Optimox 2 study designs. So in Optimox 2, what they did was they compared maintenance therapy versus chemotherapy free interval with oxaliplatin at stop and go. So the arm A was the same as in Optimox 1, and the arm B was the 6 cycles of Folfox 7, then no maintenance until progression, and then again and Folfox 7 reintroduction after progression. So the results were that the median duration of maintenance therapy was 4.8 months versus chemotherapy free interval was 3.9 months. And the maintenance strategy as shown in the curve, there were significant improvement in the PFS and the duration of disease control. That in the maintenance arm, this duration of disease control was 13.1 months versus 9.2 months in the chemotherapy free interval arm. And similarly, PFS was also 8.6 months versus 6.6 months. There's 2 months of PFS advantage with maintenance therapy as compared to the chemotherapy free interval. But however, they couldn't get a significant OS benefit. So based on this trial, they concluded that chemotherapy discontinuation cannot be decided before therapy is initiated in patients with advanced colorectal carcinoma. So in the next
you have another 7 minutes. Okay.
Okay.
Yeah.
Yes. So in the next trials, for subsequent trials, what they did is that they stratified patients after initial they randomized patients on maintenance versus observation after initial stable disease or partial response to induction chemotherapy. So first trial in this subset was a phase 3 Cairo trial, which compared maintenance bevacizumab plus capecitabine versus observation in metastatic colorectal carcinoma. So the primary endpoint was PFS2. That was time from randomization to progression upon reintroduction of Capox plus bevacizumab. PFS2 considered equal to PFS1 in patients who do not receive Capox bevacizumab reintroduction. So the median follow-up of the study was 40 months, and in the results they showed that the median PFS1 compared with observation was 4.1 months versus 8.5 months in favor of maintenance. Median PFS2 was 8.5 months versus 11.7 months in favor of maintenance group. median time to second progression was 11.1 months versus 13.5 months in favor of maintenance. Median OS was 18.1 versus 21.6, almost similar. The maintenance treatment was well tolerated in the study, and the global quality of life did not deteriorate during maintenance treatment and was clinically not different between the treatment groups. So second trial was a AIO 207. It was a non-inferiority study. It was mainly planned to compare the doublet 5-FU bevacizumab maintenance versus bevacizumab alone. So this they took a time to failure strategy. So in the results, we can see that the the PFS with 5-FU plus bevacizumab was median PFS was 6.3 months versus 4.6 months. Though not statistically significant. So and the quality of life was also maintained. So this study concluded that bevacizumab alone is non-inferior to 5-FU plus bevacizumab maintenance. Similarly, the most recent trial was an umbrella trial Focus 4N. In the Focus 4N subgroup, they compared active monitoring versus capecitabine single agent maintenance. They did 1:1 allocation, and in the results, they showed that in the Kaplan-Meier plot, the median PFS in the K arm was 3.88 months versus 1.87 months in the active monitoring arm. However, there were no OS advantage in the between the arms. So compliance with treatment was good in both the arms, and toxicity from capecitabine versus active monitoring, as was expected, with more than grade 2 fatigue seen in 25% versus 12%, diarrhea in 23% versus 13%, and hand-foot syndrome 26% versus 3%. So these were mainly the toxicities that we routinely see in our day-to-day practice, and they were well managed. And the quality of life showed no notable difference between the groups. And there was a suggestion that pain and discomfort might have been experienced less within the capecitabine maintenance arm. So next is the systematic review of the articles that compared mainly maintenance versus observation. And in this forest plot, we can see that the almost all the studies have shown a PFS advantage and some OS advantage with that favors maintenance. So after the systematic review, they showed that the algorithm should be first line in 5-fluorouracil with oxaliplatin or irinotecan with or without bevacizumab if they had a stable disease, or better with at least 16 weeks of 5-FU oxaliplatin or irinotecan. So they can switch to maintenance with 5-FU monotherapy or 5-FU plus bevacizumab. These both are preferred regimens. So, and on progression, we can again start the same regimen that was used before. So, and or switch to second line regimen that was not used before. So in conclusion, for patients with metastatic colorectal carcinoma who achieve at least a stable disease after a specified period of induction, that was 3 to 4 months, a maintenance strategy with at least the fluoropyrimidine with or without addition of BEV is preferred, and the optimal maintenance strategies should be dependent on factors such as patient preference, cost of care, and potential toxic effects. So I will conclude with this. I will ask my fellow speaker to start.
Thank you, Shashwat. That was a decent effort. Any questions from any of the residents or any of the faculty? If you want to ask Shashwat, or else, I'll want to ask him a couple of questions. I mean, anyone? Okay, I can't see anyone raising their hand or wanting to ask a question. Okay, so Shashwat, two things. One, you've not quoted any data in those who are RAS wild type. What would you do in those patients? Is there any evidence for that?
Is it, there are in rats, wild type, they have the maintenance of cetuximab and panitumumab has been tried in macro 2 Valentino trials. So uh, targeted therapies are also option in those subgroup of patients, but because we in day-to-day practice and because of cost advantage in maintenance, we usually regularly use capecitabine 5-FU based. So I have mainly focused on that part only. So I have not included those studies in the presentations.
Okay, that's a fair call because you have now at least 3 to 4 studies, the COIN, the Panama, which have shown that 5FU plus cetuximab or panitumab are worthwhile options. Two, while you had presented all the evidence, it didn't conclusively tell me why I should opt for maintenance because you yourself said that there's only PFS benefit and no OS benefit. So how will if your patient says I'm not going to survive longer, how are you going to explain that to him when you're going to consider maintenance?
First thing that in colorectal carcinoma, as we know, survival is overall, we expect a decent survival in metastatic setting also. So even after first line failure or second line failure, we have a lot of choices of subsequent chemotherapies. So OS is not a proper endpoint in this kind of setting where we have different regimens, we can have crossovers, and we can't compare the OS actually. So either a PFS1 or a PFS2 can be a better endpoint in this kind of setting that can tell us whether a maintenance is effective or not. And similarly, sir, so if you see in all the maintenance strategies versus observation, there had been at least a 2 to 4 months of period where we can use some capecitabine or 5-FU based regimen. Those things were less toxic and well tolerated. So if we opt for them, then the quality of life is also maintained as well as the disease is under control. So at least 3 to 4 months of decent period of intensive chemo, free from intensive chemotherapy.
Fair, fair. I mean, we should also remember that approximately 40 to 45%, only around 55 to 60% of patients make it to second line. So maintaining them on some kind of therapy might be a useful option. I agree with you. Akhil, any questions?
Yes, sir. I was going to ask the same thing. How many patients will be able to receive second line treatment in both the arms? That is an important parameter to look at.
Yeah, yeah.
It will.
I agree completely. So, I mean, you obviously know the data, Akhil, but just for reaffirmation, in older trials, 2005, 2010, it was approximately 62 to 75%. Our own data says 60%, I think, 55 to 60%. This we have sent for publication. So, a fair number likely come back in a state where you cannot treat. So, maybe maintenance is a way there. Yeah. Anyone, any other questions? If not, then we'll move on to Ashutosh. Ashutosh, all yours.
उधर से पिक करो मैं इधर छोड़ेगा कोई क्या
Okay, yeah. Okay. Yeah, Ashutosh, go ahead.
Yes. Good morning, teachers and colleagues. I will be speaking for no maintenance strategy. So what should be the ideal maintenance therapy? Ideal maintenance therapy should have no toxicity or limited toxicities. It should have led to improved overall survival or at least meaningful progression-free survival. There should be no repeated hospital visits during a maintenance therapy, and it should be cost-effective and accessible to all patients. So as discussed previously, initially when FOLFOX4 until progression was the standard of care, first Optimox 1 trial came into the picture when it introduced 5-FU as maintenance therapy. So results have been shown previously. Limitations of these trials were actually in maintenance arm, and FOLFOX7 was used. oxaliplatin dose intensity was 37% higher in FOLFOX 7 based arm. So this might be offsetting the effect of discontinuing oxaliplatin. In FOLFOX 7 arm, oxaliplatin dose was 130 mg per meter square, while it was 85 mg per meter square in FOLFOX 4 arm. Also, the 5FU regimens were different in both the arms. FOLFOX 4 used bolus regimen, and this FOLFOX 7 used infusional regimen only. In maintenance arm, only 40% patients had per protocol reintroduction of oxaliplatin. So reasons for not introducing per protocol oxaliplatin at progression were early progression in 18% of the patient, chemotherapy related toxicity in 18% of the patient, residual peripheral neuropathy in 11%, secondary surgeries in 30%, and no specific lesions in 17% of the patient. As well as there was no QOL analysis in this trial. Second trial, which compared maintenance therapy versus chemotherapy free interval, was Optimox 2 trial. So as previously shown in results, it has shown improvement in progression-free survival and duration of disease control, while there was no significant overall survival benefit. So one possible reason for reduced effectiveness of the chemotherapy-free strategy or chemotherapy discontinuation strategy may be the fact that chemotherapy was stopped early. So in chemotherapy-free arm, chemotherapy was stopped only after 3 months of therapy in all the patients. And overall survival was similar in both the arms. So the reasons for this may be at FOLFOX reintroduction in maintenance therapy arm, only 44% patients were able to receive FOLFOX at first progression, while in chemotherapy free arm, 63% patient could receive FOLFOX reintroduction. Overall, after reintroduction of FOLFOX, higher response rates were seen in chemotherapy free arm. It was 30% in chemotherapy free arm versus 20% response rates in maintenance therapy arm. And also at that time, bevacizumab based induction have become a standard of care. So this study was prematurely closed with 1/3 of the planned patient recruited, so limiting the power of the study. This is the retrospective analysis of Optimox 1 and Optimox 2 studies. So it suggested that significant number of patients in this study might have benefited from chemotherapy-free interval. But at the baseline, we don't have any baseline characteristic or biomarker which can suggest which patient will benefit from chemotherapy-free interval. So this we only can come to know after induction chemotherapy. Those patients who are showing stable disease or partial or complete response might benefit from chemotherapy-free intervals. So this hypothesis was tested in Cairo 3 trial, which randomized patients after induction chemotherapy. So after induction chemotherapy, those patients who were having stable disease or more response were randomized into observation versus K plus Bev arm. So as shown previously, this study achieved its primary endpoints in PFS2 and time to second progression. But this came at the cost of significant grade 3 and grade 4 toxicities. So as we can see, grade 3 or grade 4 toxicities in the maintenance arm were almost 60%, while these were 34% in the observation arm. And main grade 3, grade 4 toxicities are hand, foot, skin reaction, so which were in 23% in the maintenance arm, while 0% in the observation arm. Other limitation is that Cairo 3 study population is highly selected population. They after induction chemotherapy, they have selected patients who have stable disease or more response, as well as they've excluded those patients who had not tolerated induction chemotherapy well. So they have selected only those patients who have tolerated capecitabine well. And in this study also, after PFS1, 60% patient in the observation group versus 47% patient in the maintenance group received Capox-V. So those patients who are receiving maintenance maintenance capecitabine plus bevacizumab, less percentage of the patient could receive reinduction after PFS1. Next study was AIO 207 non-inferiority study, so which tested non-inferiority between Cape-Bev versus bevacizumab or Cape-Bev versus no treatment arms. So again, limitations of this study are a low frequency of reinduction. Only 19% patient in the combination 5FU plus Bev arm could receive reinduction at first progression, while 43 and 46% patients in the other arm could receive reinduction at first progression. Also, the upper boundary of the non-inferiority margin was generous. It was 1.43, which is usually higher than other studies which use non-inferiority margin of around 1.5 or 1.2. So hence assessment of non-inferiority was limited in this study. The next trial was Focus 4N trial, which compared capecitabine versus observation. So it has also achieved primary endpoint of progression-free survival. However, there was no overall survival benefit. However, this improved PFS also came with the cost of increasing toxicity in terms of significantly increased grade 1, grade 2 diarrhea, fatigue, nausea, skin rash, and palmoplantar erythrodysesthesia. And Focus 4N trial, initially 644 patients were planned for randomization. However, accrual stopped due to some reasons after 254 patients. And also, this trial has showed inferior overall survival as compared to other trials. One reason may be that bevacizumab was not used in induction chemotherapy as well. And only 16 weeks of induction therapy is used in Focus 4N trial, while 18 weeks of induction therapy in Cairo 3 and 24 weeks of induction therapy in AIO 207 trial was used. And PFS might seems to be an weaker endpoint for this study of maintenance therapy, because in maintenance therapy we are giving one arm as some form of therapy like 5-FU or capecitabine, or the other arm is on observation only. So PFS2 or overall survival could have been a better endpoint. Then coming to the meta-analysis. So this meta-analysis also showed progression-free survival advantage, but there was no overall survival advantage. However, these studies included a heterogeneous patient populations, and there were different primary endpoints in trials. Some trials used primary endpoint as PFS, some used PFS2, and some used time to failure strategy. And duration of initial induction chemotherapy was also different. And in all trials, outcome assessors were not blinded. Only in Cairo 3 study, outcome assessors were blinded. So there might be a detection bias in other trials. So as they have concluded from this meta-analysis, CAPE-BAVE or CAPE-based maintenance therapy as well as observation is also an alternative preferred option for maintenance. So in conclusion, optimal maintenance strategies should be dependent on the factors such as patient preference, cost of care, and potential side effects. And given the lack of OS benefit, observation remains an acceptable alternative valid endpoint. Thank you.
Good presentation, Ashutosh. At least you made it more like a debate in the sense you clearly answered the points on various trials. Any of the faculty or residents want to ask a question to Ashutosh? Anyone?
Anand sir, hi, Lingraj here.
Yeah, please go ahead.
Ashutosh, you showed about Cairo 3, and Cairo 3 has PFS2 as the endpoint, right? I think it seems that Cairo 3 is the most, or I can say the best design to answer that whether maintenance helps. If overall survival is the best endpoint, I think the next best endpoint is PFS2. So
Yes.
that has shown improvement, right, in Cairo 3.
Yes.
So what are your counter like that? Why you think that maintenance should not be given if PFS2 is prolonged? What are your main arguments against Cairo 3?
So my main arguments are first is increased toxicities. So they have showed although QOL was maintained, but almost 15% patients in maintenance they had to reduce doses of capecitabine, and grade 1, grade 2 toxicities as well as grade 3 toxicities were significantly higher in the maintenance arm. Second thing is Cairo 3 population is a highly selected populations because they have randomized patients after stable disease, or means after induction chemotherapy they have randomized patients, and they have not taken patients who have not tolerated induction chemotherapy. So from the outset they have excluded patients who have not tolerated capecitabine, and they have taken only PS0 or PS1 patients. They have not taken PS2 or more patients.
So in that situation, will it affect the PFS2? The points that you said, will it affect the PFS2? I don't know, like Anand sir can answer this. So the points that you have said, so if the PFS2 is prolonged, then I think the same analogy I can use from myeloma trials where we use maintenance, and when the second PFS is better, then somehow that is acceptable in the myeloma field. I don't know about colon, but Anand sir can answer that. Thank you.
So first, I think the reply which Ashutosh gave was very, I mean, very to the point. So as Dr. Lingraj said, PFS2 has been seen best in this trial, right? And they clearly showed a benefit, right? But there are two things to that. When you're having an intervention, the fitter you are at the baseline, the better you're going to tolerate it. So this could be a reflection of that, which is what Ashutosh was referring to. If you're taking patients who are going to tolerate treatment better already, and they're only PS 0 to 1, which is not often seen in clinical practice, they are going to do better, right? So that's like heads or tails. The PFS2, if you want it as a endpoint for a maintenance trial, this is the best trial, and it showed an improved PFS2. So it is a positive trial. But the counter to that is the proper selection and to know its benefit, as I think Akhil has said in the chat box as well, right? So you have taken the best endpoint, but you don't have a OS benefit. Now, obviously, the trial is not planned for an OS benefit. So, you can't say that is a criticism of the trial, but it didn't show an OS benefit despite a clear PFS2 benefit, right? So I think that's the way to look at this trial. Does that answer your question, Lingraj?
Yeah. Thank you. So I think in myeloma studies, somehow, people have accepted that PFS2 is okay because we have multiple lines of therapy after that. But I don't know how many lines are available to in colon trials. So if, as Akhil said, that if there is a PFS2 benefit in a colon, I think there has to be an OS benefit. Barring that we have what is available. You have regorafenib and
so I was just going to ask.
Yeah.
I was just going to come to that, Ashutosh. If you have a patient in, let's say, India, right, who a routine patient who comes to you, you would be able to give a maximum of 3 lines of therapy usually, right? You have irinotecan based, you have oxaliplatin based, and regorafenib, right? In that scenario, what are your thoughts on maintenance versus no maintenance?
So first,
because you said no maintenance, right?
Yes,
and
yes.
The caveat is that only 55 to 60% of patients come for second line. With that in mind, what would you?
So if that patient has tolerated induction chemotherapy well, so there is likelihood that he will tolerate maintenance therapy also. And in these trials, the per protocol reintroduction of oxaliplatin was not as much as in the observation arm, but later on they could introduce oxaliplatin into some of the patients. So this we can discuss about the options of maintenance chemotherapy, their toxicities, and their benefit of this 2 to 3 months in form of freedom from injectable chemotherapies. So both options are valid as maintenance as well as observation, because ultimately overall survival will be same only.
Fair enough. I agree with you, because in the Cairo trial, they actually used a much lower dose of capecitabine. They used 1250 milligram per meter square per day. Yes. Despite that, a fair number of people had HFS and some quality of life issues, though it was maintained overall. So I think the way to go is that when you begin treatment, you cannot decide whether you're going to give maintenance or not. Post an induction and around 4 months or 6 months, I think 3 months is a little early. 4 months or 6 months, you can consider maintenance if the patient has tolerated the induction well. And maybe 1250 milligrams, since you have a prospective trial, is the way to go. Now, one thing that we should not forget is that in those who are RAS wild type, there are strategies for 5FU plus panitumab or cetuximab. Both these drugs actually affect quality of life to a certain extent. The skin rash and mucositis is not easy for a lot of patients. So, that should be kept in mind when we are discussing RAS wild type patients. Bev plus CAPE at a lower dose, I think, is very well tolerated. So, that is a valid option. Those who have not tolerated the initial chemotherapy well, trials like the Focus 4N give us confidence that maybe you can offer them a chemo-free interval, allow them to recover, and then treat them at progression. At least that's my take from the evidence that's available. So Lingaraj's question, Dr. Lingaraj's question is role of maintenance after cetuximab induction. How do you personalize maintenance in real practice? again, this goes back to what Ashutosh had mentioned. Your tolerance to initial therapy kind of predicts your tolerance to later therapy with cetuximab. If you've not had significant toxicities, and the major toxicity, of course, is the rash. You know, in case the rash is controllable, you should go ahead with cetuximab. I would actually be happy just continuing 5-FU alone in such patients, or capecitabine alone. As an individual agent in maintenance, cetuximab is a very weak agent. So you would want to concentrate on the chemo backbone rather than the anti-EGFR. I think that's what I would do, and that's what the evidence says. Yeah.
Yeah. Is there any good data after cetuximab-based induction use of Cairo 3?
Sorry, Lingraj, I couldn't get the whole thing.
Is there any good data? Is there any data of cetuximab-based induction and using maintenance and showing a benefit as opposed to Bev-based upfront induction? Is there any good data of maintenance, like using 5 if you keep cetuximab or 5 cetuximab as a maintenance after a cetuximab-based induction? Is there any good evidence for that?
So you're saying that you will give FOLFOX or FOLFIRI plus cetuximab, followed by 5-FU or K plus cetuximab. One of the anti-EGFR. Right?
Yeah.
Cetuximab there are, I think the COIN B trial was there. This was an older trial, 2014, I think. And the most recent in this space is the Panama, where they gave chemo plus panitumumab and then continued 5-FU plus panitumumab, and 5-FU plus panitumumab had some PFS benefit. Or again, these are all 2 to 3 month benefits, but it's there,
It was a
there.
positive trial?
Yes. But with a whole lot of caveats. Okay, I mean, you should read the trial to understand that there were a lot of statistical issues with that. But yes, the PFS in the
what I can make out,
it was around 9 versus
Bev-based induction. Bev-based induction and maintenance seems to have a better evidence than cetuximab, right?
No. Similar, Dr. Lingraj. So the quantum of benefit is somewhat similar. 3 months, 2.5 to 4 months. Okay, that's what I'm saying. The thing is that it's far easier in our setup to give Bev because cetuximab and panitumumab are that expensive. But there is decent data for both, right? I mean, if that's what you want to know. Yeah. Anyone else? Akhil, anything? Anyone else?
Sir, I was just sharing the experience for cetuximab maintenance, which we use commonly in head and neck cancer. So similar is the case. The toxicities of cetuximab maintenance in the initial induction part, where we combine usually with paclitaxel as well, the maintenance is also goes quite fair. So that is what is same for us.
We definitely underestimate the rash and fatigue that cetuximab panitumumab causes. A lot of patients want to stop, and this we only get to see once we give it to that many. I agree with you. Yeah. Anyone else with any other question? Residents or faculty? I don't see anyone. So Shaswat and Ashutosh, good job. I think you guys brought out the points very well. It would be nice if you were a little more aggressive in your pro and against, but you guys quoted the evidence well, so good job. I think I'll hand over to Kumar sir now.
So thank you, Anand, and nice discussion. I enjoyed both the presentation and discussion. 2 comments from my side, one on PFS2 and another one on cetuximab. Cetuximab with RT in head and neck, when they compared with cisplatin, they have not been able to prove it is safer as on date. Whenever they did it, it turns out to be side effects are different, but potentially they have ultimately turns out to be grade 3, grade 4 side effects are similar in both arms, and that too comparing 100 milligram per meter square of cisplatin. But yes, side effects are different. Coming to PFS2, that is a bit of a problem. PFS2, first, how do have them defined? That becomes an issue. You define from because this was one of the comment by editor for one of our paper, from day 1 to second line treatment, or after the patient has completed second line treatment, and third, you take the whole population or who had only progressed. And the moment you divide, and we, in fact, this is in our paper of JFGC paper, because that is what editor wanted, and it's intriguing to see that someone wants will be happy to show. If you do these all different types of analysis, you do get different kind of results. So that is one to closely look for. Second part will be PFS2 will also have an implication what happens in your clinic. So think about, you have a far more effective drug which is there, which you can give in first line, and second line you have a 3 drug available which you are not able to give it. If Anand is able to give it, his PFS2 will be different. If I am not able to give it, my PFS2 will be different. So your PFS2 also has to bear in mind what you are able to do it in the clinic. So to see what the outcome happens. Another part of again PFS2 issue remains. The PFS2, when those 10%, 20%, 30% patients are having the different kind of treatment, then what kind of implication you have that PFS duration? So if OS is your primary endpoint, it's doing good, be happy with it. PFS2, no details. I'm not saying it is not. It reassures you. This happened. One of the another aspect where PFS2 was brought in picture was when the immunotherapy in lung shifted from second line to first line. So this issue came up there also, and they could show it that PFS2 is better. So people got reassured more. But again, I'll say to remember the other aspects for PFS2.